Okay. Hello, everyone, and welcome to our Ground Rounds. I'm Roxana Lupo. I'm the Vice Chair of Internal Medicine, and our speaker today is Dr. Qamar. He's originally from Pakistan. He graduated from Aga Khan University. He did his residency and fellowship at UPMC, and he's double boarded in internal medicine and nephrology. He's also an assistant professor at the USD. He is married, he has two wonderful children, and he's my neighbor. So we rely on his expertise in the hospital where I work with him and in the clinic. Please welcome Dr. Qamar.
Hello. Okay. Good afternoon, everyone, and thank you so much for coming. Thank you for the introduction. First of all, I don't know about the wonderful kids, but we'll take the rest of it. So, when I was called to give a talk on Grand Rounds, I was thinking about the topics to present, and this topic came up because I had really found out about this myself in the last year. And it's an entity that, to be honest, the vast majority of physicians in the U.S. are probably not aware of, including nephrologists, because this is not something that we encounter on a regular basis, if at all. And this has been sort of under the radar in the rest of the world as well, up until perhaps the last 4 or 5 years. So there's been renewed interest. You may have caught like an article here or there on CNN or some news network about this sort of mystery illness that's been striking people mainly in the Pacific coast of Central America, with some implications in parts of South Asia or Africa. But it really has been, I would say, underdiagnosed and perhaps not focused upon, primarily because most of the places where this has sort of become almost to epidemic-like proportions are poor areas where there's not a lot of medical facilities. So it's really not diagnosed early enough. But what we can tell from data that we have available now is that this has been going on for at least the last 2 decades, and perhaps even longer than that. So in this talk, I'll go over, I'll give a brief introduction about this entity. We'll talk about the epidemiology and the global implications of this condition, along with the risk factors and the etiology or etiology.
I don't feel like that is terribly well-deserved, but we'll try to do my best to make sure I live up to that.
So the crux of this talk will be about epidemiology.
As part of my new role, now that I've moved out of hospital medicine and more into telemedicine, we're going to talk a little bit about telemedicine in general, and then we're going to talk a little bit more about
briefly, let's talk a little bit about chronic
in
kidney
telemedicine for long-term care.
How do we diagnose?
There's a lot of stuff happening out at the very
the
helm
National
from
Kidney
a
Foundation
telemedicine
has given us a
standpoint.
definition.
I don't have all the information
kidney
about all
damage
the
for 3
specialties
months
out there.
or
I have a
more,
little
with
bit
or
of that. If
without
you have
a
questions
change in
about that, you
GFR,
can ask.
or if you
I
have a
may or may not
decrease in
be able to
GFR
answer.
of less than
Certainly
60,
with what we're doing
with or
in
without any
telemedicine,
evidence of kidney
I'll
damage.
be able to help you.
Kidney.
So you'll see a
And by
little bit of
confusing you now,
introduction on
welcome to the talk.
telemedicine. Some of that will be
Both of
woven
these
into the
treatments,
geriatrics
if you look at them
literature
on
because
surface,
that's kind of what I was
they would,
focusing on
put
more
you
than
sort of a
anything
fit. And
else.
as I was
Some of that
making
will
this
be
presentation,
general
a friend of mine
telemedicine.
sent me a joke on
And so
WhatsApp,
we'll have a
and
little bit of a
there's a
discussion
popular
about
show
that,
out,
and then we'll talk about
it's seen it called
kind of what's been
Game of
going
Thrones,
on.
they try to,
Some of the studies that are out there and published currently, and then our own results. So we did have our facility from a CMMI award, so
most likely be
is,
like this character on that show,
under the CMMI
which,
grant that
controls
we make this
actually controls
presentation,
everything,
so
is
you have to know
fiendishly
that
hard to understand, occasionally insane, and often unfixable, which most residents,
what is telemedicine?
especially when I was going
So
through
there's
it,
lots of different
with
ways
a
that
lot
people
of
call
information.
telemedicine and
nephrology
those types
is
of things.
Peter
And
Bailey,
so I think
Game
the
of
first
Thrones.
thing you need to look at is
But I digress.
telehealth is
So,
different than telemedicine.
Let's discuss the etiology of
some
CKD,
people's eyes.
kidney disease.
Telehealth
Now,
is looking
8 or 9 out of
over
10
just
all
not,
patients walking into my clinic would
physicians.
either come there
Telehealth
for
includes
CKD as a result of diabetes or high blood pressure.
anything done
The
over
remainder,
telephone
through
or video,
various percentages,
anything
would have
done
either some sort of
electronically,
GN or
sitting
polycystic kidney disease or some
than
obstructive
everybody else. So I
uropathy.
think that's probably
Medications play a
the
role
umbrella
certainly as
term
well,
that covers
especially
everything.
NSAIDs and obesity.
Under that,
But the
telemedicine
bulk
is
of
one of
patients
those
would
things.
either have high blood
Telemedicine
pressure or
is
diabetes
having
or
a
a
provider
combination
on
of
one
both.
end,
And this is a global problem, and it
something
is
on the
still
other end
perhaps
that you're providing.
CKD itself is underdiagnosed
Mobile
and
health is a little
underappreciated
bit
in
different.
the
That's
world
kind of
because,
like what I have on my wrist here.
even
Mobile
in the
health
US
is
and
more,
wealthy
I
nations
wear
such as the US
something
and
that
the West,
tracks my
a lot
health
of patients
activity.
are not
If you look at
diagnosed
my
with
health
CKD.
activity, it is terrible.
And
do a
we
very good
suspect
job,
that
so
between 5
I
to
do make
10%
it
of the
to
world's
stand up 1
population
minute every
is dealing with chronic kidney disease, which is
all I make on my mobile health goal.
500 million to 1 billion patients.
Mobile health now is talking about
the ISN
transition from
put out this really nice poster
mobile
a few years ago.
device
this is
to a provider,
which is the
and then
Global
how
Burden
does that
Disease
impact my health?
which demonstrated the scope of the problem. So just plain CKD,
I included it on here more as
almost 1 million deaths annually linked directly to chronic kidney disease.
So mobile health is
and the incidence of deaths,
telemedicine,
from CKD has actually gone up by more than 130% in the last 2.5 decades. So it is a huge problem, and the last thing we want is for a new entity to sort of come board and make this problem
so we all know that
that's
there's
why
a physician
this
shortage.
This,
if
this
you look
diagnosis
at
of CKD
any
etiology is
specialty,
so critical going forward.
Physicians, and there's a shortage of physicians everywhere.
Why use the term CKDu?
By adding telehealth,
why don't we just
somewhere
say,
you can
why isn't there
have
sort of
a little bit more access
why this
to
unknown associated with this?
Providers of care.
And in order to go into
Improved
that,
care and
we have to
outcomes.
first,
So the hope is
ask
that
ourselves
in that
basic questions.
improved access, we're improving access
First of all,
to specialty care.
if we look at regular CKD, who gets it? So normal CKD, what you would see is generally older people, and you'd see males and females perhaps in equal amounts.
Cardiologist or
CKDu generally affects young and middle-aged males between the ages of 20 to 50, and predominantly by a factor of 9 to 1, it's males, young men. What are the risk factors? Again,
improve workforce sustainability. So this,
diabetes, high blood pressure.
that is a little bit more nebulous. How does it improve workforce sustainability? I think it allows for a different challenge than what medicine has always faced in the past, and so it's allowed people that maybe have been kind of fatigued or burned out, as the now popular term is, to move into something that maybe is not quite as difficult and maybe a little more sustainable.
Again, when we
and then hopefully lower costs. So one of the other ultimate goals is to improve costs. That comes with improving outcomes. So if you can improve outcomes and improve care, you should be lowering costs. So you would think that those two go pretty well hand in hand.
Finally, hematuria.
Hopefully you're not lowering costs because
but we
it's
do
not
see them in
as
a lot of patients, especially with IgA nephropathy or some sort of mechanical obstruction. Or
types of applications. So I just went.
which again is
This
not a
slide
hallmark of
came
CKDu.
from this
Right
website
off
here.
the bat,
But the other thing I did is I just did a quick PubMed search. I just typed in telemedicine into PubMed.
Affects people that
If
are,
you just go type in telemedicine into PubMed, you're going to find that they
plays a
are
big role
doing
in this.
everything that you can think
And I'm going to jump ahead. Usually we discuss pathology, towards the latter part of the talk, but I wanted to discuss pathology of this condition.
There is a lot of experimentation.
Until very
right now
recently,
with
we did not
telemedicine.
have kidney biopsies.
I devised it into two
it
different
was very
groups.
recent
They have
that this
disease-specific.
identified.
So there's a lot on telestroke.
Biopsies,
There's
and
some
this
on
is,
teledepression, some on
article
teleskin
in
cancer, some on COPD management
recently.
via
What it showed
telemedicine.
was this, the picture on the left is a biopsy sample, a kidney biopsy sample from some.
I guess I'll stand behind the podium.
And most of the changes, so I know that it's sort of hard to make
I'll
out
just
what
hold
you
this.
can see in the pointer's working or not.
So disease-specific,
but
COPD,
generally
skin
see
cancer, all of those
non-specific
things.
changes,
We're
non-specific
really
from
focused on an
fibrosis,
illness
you have this
or a
pattern of
disease
injury,
process as opposed to anything.
some mild vascular
And then
changes.
there are
And on
more the
electron
focus
microscopy,
on
you
the
don't really see
medicine
any
specialty.
deposition.
So they
You
have
don't see,
cardiac telemedicine, pulmonary
process
telemedicine,
basement, which
we're going to
generally
particularly talk
in
about
other
long-term care,
categories of
that's what we do.
CKD, you would probably
Psychiatric
see other
medicine,
changes,
radiology.
not just
Radiology is probably the first or the
I
pioneer
wanted
to
to show you a
telemedicine,
brief slide
and they're the ones that kind of started this whole thing
of
where you
what
have
common-
somebody read your
common
x-rays who
associated
lives
CKD
in
looks like
Australia
under the
during the
microscope.
daytime while
So
you're
the
sleeping
picture on the
overnight.
top left
Here.
is a slide of
Gastroenterology,
normal
which I was like,
So
I
you have a normal
gastroenterology
sort of
over
Zangian,
telemedicine, but
normal
interesting that they have stuff like that. Teletrauma,
bottom,
telenursing,
just below that
telepharmacy,
is
school.
a slide from
We do school
diabetic
nurse out
nephropathy.
at
So
here right now.
right away you
currently,
can
and
tell that there's an
I
expansion.
did not
of
find
action
any
within the
resources
glomerulus.
on that
You
when I
actually
searched
see these
PubMed,
classic
but
nodules
that was
inside the glomerulus,
something that we do
or
currently.
commonly referred to as the Kimmel-Steele-Wilson body
When you
scheme in
talk
diabetic
about
nephropathy.
telemedicine, you can talk about
Picture
two
to
different
your
ways
left
to do
is
telemedicine.
classic
So there's
example of
asynchronous,
hypertensive nephropathy.
meaning that
So
it's
you
not
can
happening
actually
at the
make
same
out sort of this
time.
onion peel-like
And most of
appearance
those types of
when
things,
there's
text
thickening of the
messages, so
arterial, changes in
Avera
the
is another good example of
this is
that.
very
They have
different
text
than,
messaging that they
typical
use a
biopsy
lot
from a
now.
CKDu patient.
So we have secure texting and we text back and forth information,
Talking about
which is
the etiology
asynchronous
of
because
the
I'm not always
implications of
on
this
that
condition,
app and
why are we
texting
talking
back
about it
right
in the
away.
US if
And
it's,
so
we really
it's
don't
not
know
at
if
the same time.
come this far
Video
or not.
recordings. That, I think, is used a lot in applications such as dermatology, where they're looking more at skin cancer, and so they're doing a video recording of that and looking at that. Email certainly is something, and then pictures/images, also used mostly in teledermatology. We don't have, the laws in the United States don't allow us to do as much asynchronous type stuff as they do in other locations. So on the national committee that I sit for telemedicine, we have somebody that's from Canada, and in Canada you can actually take a picture of a dermatologic issue, you can send it to the dermatologist. The dermatologist then will review it and send you back a response, and that is actually billable. Here in the United States, that's not possible. And then there's the synchronous form of telecommunication, which is what most people think of when they think of telemedicine. Synchronous telecommunication. I'm on video now giving this presentation.
So it is being identified as a cause of CKD in nations such as
this room that are watching at the same time. And then you can also do that, we can also do that over the phone. That's probably one of the oldest forms of telemedicine. I guess radiology technically wouldn't be the first, because what they, when you look at these review articles on telemedicine, they talk about how the ships out at sea would have telehealth over the radio out to the ship captains to help them figure out how to keep their
Ebola killed about 14,000
crew
people in the
on
last
board
40
without
years,
having to
which is a
count
huge
for
number.
sure.
But everyone knows about Ebola.
Currently,
no one
some of
knows
the
about this
challenges
other
with
entity, or at least it's not on
telemedicine
your
right
radar.
now are laws. So parity laws are laws that allow for payment of telemedicine. And so here you can look at all the states. The states in orange have parity laws and do allow some bit of payment for telemedicine. The states in dark blue do not have parity laws and have a little bit of plans for legislation on that. As you can see, our state of South Dakota is one of those. So we don't have any parity laws right now, and so that's, I don't know if it's created a challenge to our program, but it's something that we think about when we're building programs and doing those types of things.
Indonesia, Philippines. So it really has
other challenges in telemedicine is reimbursement, obviously, limited insurance coverage. Not all insurances cover telemedicine. Medicare, particularly, is not a big provider of telemedicine. And so that creates a big limitation for us in long-term care, because they don't provide insurance coverage for telemedicine. Excessive use of healthcare. So what I mean by that is the reason that it's been limited in reimbursement is because the Medicare has been concerned that it's going to cause an excessive use of healthcare. So by having easy access to a provider, by being able to just call me up on video right now, that may cause somebody to be pulled up more often than they actually need to be seen. Some of the clinical issues that they're finding is some concern over quality of care. So is care done over the telephone or over the video camera as good a quality as something done in person? Overprescribing, it's a little bit easier or maybe a little bit harder, since maybe you don't have as good of an exam to maybe prescribe an antibiotic or an antipsychotic.
So what are the risk factors?
That would be very easy to do over the phone. I'm looking at you, I can just say, oh, we're going to treat you now with an antibiotic, because it's questionable whether or not you have infection. And then fragmentation of healthcare. So that's, I think, one of the biggest challenges facing healthcare right now is all the fragmentation. We have, hundreds of specialists,
low body mass index,
and we have
the final two,
way too many people involved.
There's a little bit of debate about that, and I'll get into that later.
It's hard to say who is actually in
exposure
charge
to
of what.
agrochemicals.
And when is it your turn to make an answer? And adding telemedicine in the mix is a big fragmentation issue. So are we creating more fragmentation of care
when you think about it, if you're
going
working
in and seeing
a
this
lot
patient
of
urgently
farmers,
and ordering something?
they are working perhaps 10, 12 hours.
There's the legal issues. So right now I have a state license in all of the states that we have telemedicine in. I also have a DEA in all of those states.
And that actually increases
so
the risk of AKI.
I have, a lot of legal issues. I also have to follow all of the requirements and laws for maintaining my license, maintaining my DEA, and then not to mention who is responsible for my care, especially in the nursing home, because I'm not the primary care provider. I'm not listed as the primary care provider. If I do something over telemedicine, am I at fault if something goes wrong, or is the provider who is the primary care attending the person at fault? And so that's that's something that's being worked out. And then also the social issues. Is it socially acceptable to see somebody over camera as opposed to in person? And I think you'll find that that is probably the least challenges because most people adapt this very easily.
So heat
even
stress, let's talk a
the
little bit
older
about
population that is not so tech savvy. A lot of times they think it's very exciting. So.
How this can impact somebody potentially.
Impacts of telemedicine.
So what does heat stress do? It causes, your body to go into a state of hyperosmolarity.
Easier access. You have very quick and timeliness of care. It's very convenient. You have access to a provider 24 hours a day, 7 days a week, whereas most of the time in the nursing home you don't have quite that same access. You also have access to specialists, so in the general sense of the term telemedicine, you have access to a cardiologist when normally you wouldn't have access to a cardiologist. You can get them on the camera and pull them up and have them see the patient and help you with management. Nursing and staff facility effects, so this is specifically in nursing homes because you don't necessarily have so much of that. We do a lot of nursing education. Hopefully we're helping in recruitment and retention of nurses in the nursing facility because then they have readily access to a physician. I think some of the burnout from nursing home nurses is the fact that when you're there you don't have easy access to get information and orders of things that you need right away, so this provides that easy access. It also provides us a way to educate the nurses. So a lot of my time is spent on camera actually educating the nurses. So this is not cellulitis, this is not shingles, this is X, Y, or Z, and this is why I'm thinking it's X, Y, and Z. And so these are the things that I'm looking for when I'm looking at shingles versus cellulitis and those types of things. So it provides some bit of improvement there from an education standpoint. And then physician effects, hopefully, we are decreasing the amount of paperwork and the amount of calls that the primary care provider receives, and we're also providing that increased communication so that then they can see exactly what we did and why we did it. And then we're able to assess 24 hours. They have access to a geriatric consultation, not that I'm a geriatrician currently, but I'm working on that, so I try to do my best in creating a good geriatric assessment. Boy, this is very difficult to read, so you're not going to be able to read this. This is statistics on medical care for the elderly population. So if you look on the
talked about that enzyme aldolase reductase in the proximal tubule.
There are 15,600 nursing homes in the United States. Of those 15,600 nursing homes, there's about 1,663,300 patients.
There was a small pilot
of that, most of the nursing home size is about 88 residents per nursing home. This came right off the CDC website. So look at that. It also breaks it down for adult day services and all the other hospitals. As you can see, the largest location where the elderly are in a nursing home. 1 million, almost 1.6 million nursing home patients. And the next closest is residential care.
The more acidic your urine,
I don't know if this is 100% accurate. But
uric acid deposition.
So other industry challenges. There's one geriatrician for every 2,200 elderly patients out there. Geriatric-led results in 133 fewer ER visits per 1,000 and 10% reduction in cost per year. If you have a geriatrician caring for your elderly population, you have reduced cost and hopefully, and actually reduced ER visits, not hopefully. Studies have shown that there are fewer ER visits. The urate crystal production, there are 20% of the United States is made up of
and I wanted to sort of take a step back and not just think about this as
14 or more physicians. So as we talked about that, the difference with fragmentation of care, you can see that most of these older patients need multiple providers have a difficult time determining exactly what the right thing is, because maybe their nephrologist told them that they needed to reduce their fluid intake or increase their fluid intake, and their cardiologist has told them to reduce their fluid intake, and so how do they then follow conflicting
But it brings a big question,
By 2020, the U.S. will be lacking 45,000 primary care
we don't
physicians.
consider AKI as a cause for CKD. We generally
specialists.
expect that you have acute kidney injury,
telemedicine
you recover from that, you recover your kidney
Has
function, end of
a
story.
bridge to help
So
with
could
that
AKI be a
lack
cause
of,
of CKD? And what we also have to consider is the incidence of AKI.
There are 5 million hospitalizations annually.
Especially in our critically ill patients. Sometimes, with a mortality rate of as high as 50 to 80%.
They came out with a study a couple years ago that these are the diagnoses.
This is a really nice paper that came out a few years ago that actually looked at the
percentage of how many of those diagnoses are hospitalized, and that's how 46% avoidable. The cost is estimated to be $15 billion annually, about 11,000 per hospitalization, and so
to discuss,
to reduce
the
those
criteria that we have,
hospitalizations,
the rightful criteria that we have for
money
acute
win
kidney
for
injury.
the
We divided it into
insurance
three
and,
stages.
for the United States, really, because
One
we're
is risk,
going broke because
risk
of
for
our
injury.
health
So
care.
that is when your baseline creatinine increases by
Nursing home hospitalizations are frequently,
or you have a decrease in urine output by less than 0.5
they increase over
mg
time,
per
they're
hour
costly,
for 6
they're often
hours.
preventable.
Stage 2
Falls,
is
incontinence,
injury.
dehydration are
Your
the
serum
most
creatinine
typical
doubles
reasons.
from baseline.
A lot of
Or
times it's
there's
easy for the provider on the one end when they get a call from a nurse that says this person's doing this and
but
this
now
and
you
this.
lengthen it over 12 hours.
Just have them go in because I
Finally,
can't
the
see them
severest
right now,
stage of
see them
AKI,
till
which is
tomorrow,
stage
can't see
3,
them till
or
next week.
failure, in
So
which you have
it
a
becomes
tripling of
difficult
your
to assess
baseline
them
creatinine,
urgently
or any
when
creatinine
you're
over
busy
4
in clinic.
qualifies you as having stage 3.
Evening and weekend shifts at nursing homes are typically
or
covered
the
by a large
anuric
group
or
practice.
oliguric
A lot of
for
times they're not
a
known.
period of greater than 12
The
hours.
patient that,
Now,
passed
when we
away,
look at
you
our
find
practice,
that
a lot of our patients in the ICU actually go through this exact process. I mean, I see this on a
who
daily
was on
basis.
call, and it took
You see
me
patients that
30
come in
minutes.
with acute kidney
Who was
injury and
just,
ATN.
supposed to be
A
on
lot
call
of them
for that
become
large
anuric or oliguric for a period of time.
Provide
We
simple
never
order.
think
So
about, what are the
makes it a
long-term
little bit more
implications of
difficult and
this.
a little bit more fragmented.
So that
And
same
so
paper that I was
you can see
mentioning
why sometimes
looked at this,
it's just
and what
easier
they've
to say,
discovered
just
was
send them to
based
the
on a lot of
ED,
data that
because
they had gathered,
I don't know what's going on, and I don't
that
have any idea.
after a period of acute kidney injury, whether
When
it's
and then that
pre-renal
way we
or
make sure they get the right
ATN,
assessment.
the tubule does start to recover quite robustly.
All too often,
It's
the
actually
on-call
the
physician sends
vascular,
the patient to the ER.
reperfusion
So
that's
now we're going to
involved.
go through the
And
literature
vascular
review portion
recovery
of this.
does lag, and there are chances in which the total vascular density
There is
around the
not a
tubule
lot
may lag
when
by
you
about
look at
30%
nursing home
from
evidence.
baseline.
When you look at non-nursing
There's
home
this,
evidence, if
there's
you
a
combine
space of
all
almost cell
telemedicine
cycle arrest and
literature,
maladaptive repair in which you have excess production of fibroblasts.
telemedicine is
And when we think about
cost-effective
the scope of this issue,
patient
that
satisfying.
we have about 1.5 million AKI survivors, and
Probably not just as effective.
about a
as
fifth
in-person
of those
visits,
people
but
will
in
actually
some
progress to
situations can
CKD
be
within
just
24 months.
person visits.
And the sad thing is that only
So,
about 12% of these
studies here that
have
we're going to
seen a
talk briefly
neurologist
about.
in the
One
first
is
month,
telemedicine care for nursing home
post-injury.
residents with Parkinson's
So we
disease.
may actually be missing a lot of
So
people
telemedicine,
that have had AKI at some point, but are not being followed up and eventually develop CKD and are being missed through the system. And by the time that
When
we
you
get
look
to
at the
see them,
systematic
they've
review,
already
you
had
see that it's
advanced
not
kidney disease.
Big
So
study.
the people that are at the greatest risk are the
Interesting.
ones
I was
that
like, I can't
develop
believe they
the
even
severest form of
proceeded
AKI,
with the
which is
systemic review after
anywhere
what they found.
for a period of 12 hours.
And we're
or
actually going to talk
more,
about that one
of the
first.
serum
So
creatinine or any creatinine over 4 deserves
So
not
this
just
is
a
the
neurologist
systemic
in the
review.
hospital, which
If you look here on the
most
left-hand
do,
side,
but that they
you can
should
see
be followed
these are
regularly
the articles
after
they found in
hospitalization.
nursing home care patients. So they found some with
So,
allied health.
I wanted to bring up this map again of
findings.
the
They found some with
CKDu
dermatology, general
hotspots.
practice, neurology,
And again,
geriatrics,
as you can see,
psychiatry,
it
and
really
then
has had
multiple
global
specialties.
implications.
So that included like
Mostly
cardiology,
in regions
pulmonary
that are,
medicine, those types of
that
things.
used to be close to the equator,
They really
but
did
it's
not
actually
find
spreading
enough
further from that
articles
now.
to really make any specific
And
point.
temperature change,
So
like I explained,
this
has
is
been
what you
playing a
see.
big role in this likely. So
was
in
5 years
El
ago,
Salvador,
too, yeah.
they
So
looked at the
this was an
temperature changes over the last
Early days.
and there has been an increase of.
Interestingly enough, we just had
average
Anna do a
temperature by
search
about
with the
1
same
degree
search
Celsius,
criteria that they
which
used.
is a huge change.
Because I was like,
happening.
well, let's see if we can update this slide. And
This is a map that
so
actually
far, I
shows
think she's only found
another
about
CKD
4 or 5
hotspot,
new
which is Sri Lanka.
since that was
So there are 3 pictures on this chart. The one on the
new
left actually
literature out
shows
there on
the
telemedicine either
precipitation
since
or
5
the
years
dry zones in Sri Lanka.
All
which
right,
is
so the
brown,
Parkinson's
area in brown.
discussion,
The map to the left,
what they
to the
did
extreme
is they
right,
had
is
a
actually
single
the average
neurologist
temperature.
that had
So red means hot.
two
And the map in the
nursing
center
homes.
is actually the
69
CKD
residents
hotspot
total
in that
included.
region.
They
So
actually,
as you can
this
see,
is
there's
a
an
spectrum
overlap of
review
not just the
article.
dry zone,
So
but the areas which
they-
are the
they
hottest
looked
that
at
actually
more-
have
a
the
bigger
greatest
population,
this
and then
condition.
only looked at the ones that were provided by telehealth.
So
The age was 70
what is a typical day
population.
for a sugarcane worker?
And here's
We'll sort
their
of first go
results.
into that.
Basically,
so what happens is that they burn
The easiest way to think about this
corn
is
or
the provider
nitrogen
that
ore
looked
because
at
it
these
makes
patients
it
with
easier to
Parkinson's
cut the sugar.
or had
And
suspected
at that
Parkinson's,
time, the temperature of that
they changed management
exceeds
almost on
110 degrees
90%
Fahrenheit.
of those residents.
They work
changed
long hours.
diagnosis on a
Typically,
few
they
of
work
them,
over 7 hours a
and
day
they,
with minimal breaks.
Here
And
you can
OSHA
list
has
and
certain
see
recommendations
64%
that
or
recommend
47% of the
US.
time they added
OSHA generally
carbidopa or
recommends that if
cartilage.
you're working in conditions
a whole
over
lot
78 degrees Fahrenheit that you take 15 minutes off every hour. And if the temperature exceeds 86 degrees Fahrenheit, you take a 45-minute break for every hour that you work. So you only work 15 minutes in that hour. And do not work for any length of time, more than 6 hours.
So
if the temperature
now we're going to talk a little bit about the one study that was done.
Now, these workers are doing this work every single day.
Is probably brought the most
for years and years and years.
Notoriety to care in the nursing home.
Another,
and so this was done by
the wet bulb
Garbowski,
which is a nice way to look at how the temperature changes over the day. So their work typically starts at 5:30 a.m.
So he
and by 9:30 a.m.
looked at
4 hours
Medicare
into
and
their work,
Medicaid
they've already
certified
exceeded
nursing
the
homes. He
limits
looked
set
at
by
post-acute
OSHA
and long-term
within
patients.
the U.S. So
They looked
typically
at nursing
work
homes
another
that did
6
not
or 8
include
hours after
Interact.
this.
So Interact is, for those of you that don't know,
And a
is
typical day goes further. So this is backbreaking work.
really
It's
kind of
hard,
a
intensive, labor-intensive
term
work.
that
So
was
a
brought
lot of
about
them
to
would
say,
end up taking
if you
some
use
form of
Interact in
NSAID,
your nursing home, you reduce
for muscle
hospitalizations,
aches.
improve
They would
stay.
also
I
rehydrate
think
with
here
an
recently
alcohol or
it's not
sugar-based
gotten as
drink.
much
I
attention
explained,
lately
it's
because
the
there
most
was a new
convenient way
article
to
out that
rehydrate
said
yourself.
maybe it's not as effective.
And when they were
In those
comparing the
nursing
amount of
homes that were
calories
highly
burned by an
engaged
average
in using
farmer
Interact,
versus,
it reduced hospitalizations.
high
It
intensity,
involves
exercise,
doing
there,
different
each
types
farmer
of
is,
care along the
burning
way
the
to
amount of
help
calories
reduce
that a marathon worker
hospitalizations.
would burn.
So the
a
nursing
single
homes that they looked
and
at
they
in their
experience a
study
daily
were not
weight
using
change of
Interact.
about 2.5 to 3 kilograms.
They used the
And that's
five-star
why,
system
the
to
thinner that you are,
categorize
the more
nursing
likely
homes
that you are to
and
experience
bed turnover,
this condition.
because they wanted to try to make sure that when they were comparing
So,
their,
we talked about,
test population to their
regions that
control
are,
population,
perhaps not that close to the U.S. How does this really impact us?
Post-acute
What
patients have high
implications
turnover,
would this have to the
and
U.S.?
so
So the first thing we have to remember is that we are not immune to climate change. So climate change
they
is
did use the
occurring in the
five-star
US
category
as well.
that
And
they
this is
compared
a
to three-star
graphic from
facility to
NOAA,
a
which
three-star
shows that there's two
They had
charts
a
on
high
this. The
bed
one on the
turnover
left
compared to
actually
high bed
shows
turnover to a high bed
the
turnover.
exceptionally dry days in California. And you can see
looked
the
at,
entire
it
central
was in
California
for-profit
Valley is
nursing
in
homes.
bright red.
They only
The chart
did
on the
this
right
study
shows the
after
number
hours,
of record-breaking
so they were
temperature
only
days
between
across the
5
US.
and 11 p.m.
And save for a
and
few
10
states,
to 7
every single
p.m.
state has
weekend.
experienced
So they did not
record-breaking
go past
days
midnight,
in the last few
and they
years.
did
So
not
we're
really
already
work very
experiencing some
much,
of those changes that have happened in the
over the
rest of the
weekend
world.
as well, only during the daytime.
But nobody's really looked into this, how
Obviously, it's
would
hard to
this
blind
impact,
study
how would
when you're
heat
doing
strain impact
telemedicine.
people in the U.S.?
Sure,
So the
blind.
only study that I could really find was a small study
Sham
that was done very recently
televideo
that
call.
looked at
They
heat
couldn't blind
strain
them to
and
that, but
volume
they did
diminution
blind
in
them
kidney
to is the
function
fact that they were
and
studying
the California ag
them
workers.
for
And the background is that the
so
Central
nobody
California
knew
Valley
what the purpose of
employs
this
about
study
500,000
was.
agricultural
They were
workers.
trying to hospitalize.
The temperatures routinely exceed 100 degrees
They
Fahrenheit.
did a pre and post
20
period,
times more
so they
likely to
looked
have
at
some
the
sort of
nursing home
heat-related illness
itself
if you're
before
working in
the
those
study,
industries.
and then after the
And
study,
for their
and they
methods,
did that
they
on
went
the
around
ones that they were the
their
comparison
farms.
sites
They
as
were
well.
finally able to
They had
get
a staggered
about
start
300
to make
ag
sure that
workers
they
from
did
15
not.
different farms in
They
Central
tried
California.
to adjust for.
They did a
maybe
baseline testing of
variances
their
in care
vitals,
by,
their weights,
time of year.
creatinine,
So that's
and
why
they
did a
made them
staggered
ingest
start.
this wireless
Half the nursing homes, they
temperature
started
probe, which
in
constantly
October,
transmitted their
and the
core
other half they
temperature.
started in November.
92% of the patients
They had training sessions on how to use the camera
essentially
and
a
how to do
normal
all those
GFR
things
or
ahead of
normal
time.
kidney function at the
And
beginning.
that was completed at
And
the start
you
of the
needed to work
survey.
at least 7
I
hours.
don't believe that those training sessions involved anything about reducing
And the
hospitalizations,
results
so it's
essentially
just
showed
really
that
how you
the
use
mean
the
maximum temperature
as
that these
opposed
workers
to
experienced
a
was about
lecture
100
on
degrees
This
Fahrenheit.
is how we're going to reduce
The mean maximum
hospitalizations.
heart rate was about 130 beats per minute.
And
All
they
subjects experienced
allowed the
volume
primary
inflation
care
based on
providers
when
to-
they weighed them, they discovered that everyone had lost weight. And there was incident AKI in 35 subjects, so a creatinine increase of 0.3 or more, or over 1.5 times their baseline creatinine. And heat stress experience, so the temperature change that worker experienced correlated very highly with the chances of developing AKI. And
Can you
they
hear me
also
now?
showed was that the higher your BMI,
Okay.
the less
So
chance
90% of the providers used the service. So they left it open to the providers that went into the facilities to decide whether or not they were going to use
so this
the
is one
service
study
or
that
not.
sort of looked at this
And
impact.
at
Again,
the end of the
the
study,
scope
they
of the
had
problem is
90%
there's
of
half a
them
million
that were gonna
workers,
use
they got a sample of 300 workers.
The staff that they had at the hub site, they had a medical secretary, a registered nurse, they also had a nurse practitioner and a physician. So they had all of those available during
that are
those hours.
experiencing these high heat indexes.
The outcomes,
But migratory patterns are
I
important
wonder if it would be easy to
because
see this.
the
We'll just
leading
look at it this way and then we'll talk about
where
it.
refugees or immigrants are coming to the
slides
U.S. are the
themselves.
Honduras, Guatemala, and El
So
Salvador.
outcomes showed hospitalizations that included one midnight. So you had to go in, a hospitalization was considered only a hospitalization if it included a midnight. And they did not count just after hours hospitalization. So as you saw, the hours that they operated the telehealth was during after hours, but they did not just count those because they didn't want to confound the issue with saying, if I saw them in camera and decided not to send them in, they didn't want the next day for the primary care provider to go and see the patient and say they need to go in. So they included those to make sure that that didn't happen. And then for their cost adjustment, they assumed a $10,000 per hospitalization cost. They also tried to analyze it based on more engaged sites versus less engaged sites. You see some of those statistics here. So this is kind of the slide that shows you what they came up with here. If you look at the kind of grayish bar, that is the control group. They found a reduction in hospitalizations about -5.3. If you look at the total, that's in kind of the light green. That is 9.7. Less engaged facilities had about the same improvement as the control group, and more engaged facilities were 11.3. So they were significantly much more improved than the less engaged sites. There was an average of about $151,000 in savings per nursing home per year. The annual cost of the telemedicine service was about $30,000, and so therefore it was $20,000 net savings. So the cost, yeah.
In Sri Lanka, which again is the second hotspot for CKDu, they've had, in instance, almost 12 to 20% of this disease, and it's becoming such a huge issue because
it has to be a well-integrated telemedicine. So I think it's very similar to the Interact. So the Interact study showed if those were engaged, you have a better chance of having success as opposed to those that aren't engaged. So if you're not engaged in your process of trying to reduce hospitalizations, you're probably not going to reduce hospitalizations, which, I mean, seems to make a little bit of sense, right? I mean, if you're actually wanting to reduce hospitalizations, you should make a difference, or hopefully make a difference.
And after this,
and then here's the cost savings, so you can see treatment versus control, and then engaged versus less engaged. And as you can see, there was the difference here was about $87,000 from the treatment. So even the treatment group, the total treatment group was a little bit of cost savings, but when you looked at just the engaged sites, there was an $87,264 annual cost savings.
What they discovered was that in the regions where
$30,000 per month for the telehealth costs was assumed, and then $10,000.
And cadmium is derived from various fertilizers that are used very heavily.
So now,
the farming industry in Sri Lanka is rice farming.
Now we are going to talk a little bit about how Avera eCare senior care was formed. And so the aim of our program was to reduce hospitalizations and ED visits, resulting in reduction of total cost of care in the long-term care setting. So that was the overall goal of our program. And so then we decided, what are the things that affect that? And so we came up with 3 primary drivers. And the 3 primary drivers that we came up with were build the assessment and capability and toolkits of the long-term care facility and care team. And we talked about provide long-term care residents with routine and early access to appropriate goal-directed care. And then finally, improve management of care transitions. So we know that a lot of rehospitalizations are due to the fact of this fragmented care. When they're in the hospital, they're seen by a hospitalist. And then when they leave the hospitalist, they go back to their primary care provider, and there is little communication between the primary care provider and the hospitalist, and that little communication provides increased risk for rehospitalization. If we just take the top line, we'll talk a little bit about kind of some of the toolkits and things that we did. So we thought that Interact would be something that would be very helpful to the nursing home facilities to implement. And a lot of the nursing homes that we are involved in the beginning of our program actually used Interact. And so we thought it would be good to help support them in their Interact endeavors. So trying to get them engaged in using Interact, trying to get them to understand Interact, and trying to use Interact a little bit to help us empower the nurses at the facilities to try to improve hospitalizations. Because we knew Interact, if done right, would reduce hospitalizations. And so we actually became all certified. I was not involved at that time, so I'm not certified in Interact, but all the staff became certified in Interact. and became a champion for interact and would encourage and try to support the facility in their use of it as much as possible. And then the other thing we did is also did training sessions. So in the beginning of our study, once a month, we would provide education to the staff at the facilities, those that were wanting to be involved, and we would talk about different things. So maybe we talked about infection control one time, maybe we talked about advanced care planning one time, and we would really tailor that based on a survey that we sent to the sites of what they thought they needed to help reduce readmissions. So that's kind of how we thought we could help empower the staff, build the capabilities of the nursing home nurses, and try to improve hospitalizations based on better education, better training, better engagement from the facility themselves. Then the next piece of that was providing acute access to providers. And so obviously that is pretty straightforward. We have a nurse practitioner that's on 24 hours a day, 7 days a week, and they are available all the time to answer calls. We also have physicians that are available, so Dr. Bush and myself are available to the nurse practitioners to ask questions to and about. Dr. Kawachi also joins us in that many of the times. So we go in and do virtual visits. We have the capability to have a stethoscope. So we have a virtual stethoscope where we can listen to heart, lungs, abdomen. We have the nurse in the room at the time, so they usually provide us the physical exam. It was interesting for me to teach one of the nurses how to do a knee exam over the camera. That was kind of a fun experience for me. It was interesting. So that was kind of a fun experience, but so then that again provides a little bit of education to see what the nurses can understand from us about those types of things. And then we also have a handheld camera that can allow us to look at wounds better. So we did a lot of wound outlook for CKDu, straight in on the wound.
I won't lie and say that it's
finally the improvement of care transitions.
Get worse because
I don't know. I didn't talk about our interdisciplinary team, so I will talk a little bit about that. So the facilities themselves all have interdisciplinary teams, and we felt it was appropriate for us to also develop an interdisciplinary team. So we have at the helm, we have a nurse practitioner, providers or physicians, we have pharmacists, we have social workers, and we have nurses, and now we currently have support specialists.
In Nicaragua and El Salvador,
and
we have this initiative
that the core team meets together on a regular basis to talk about difficult patients. And so one of the things that we also provided access to was this core team of a geriatric pharmacist, a geriatrician, geriatric nurse practitioners, geriatric nurses, and a geriatric social worker. Not so much that you can get a certification in that, but somebody that spent a lot of time in geriatrics. So we would sit down and talk about residents that were having difficult issues. Maybe they were having repeat falls. And so we would just sit down and talk about that and make recommendations back to the facility about how they could maybe help reduce falls in that situation. And that meets once a week, or well, once a day actually, not once a week. So we meet quite often. Improving care and management of care transitions. As you know, this is a difficult topic. So we tried to make it as simple and as easy as possible for us. It becomes difficult to enhance and manage care transitions, especially from a telehealth standpoint, as we're not as highly involved. But what we did do is we reviewed every patient that was admitted to a nursing home. So any patient that came into a nursing home had a review by a nurse or a pharmacist or a geriatrician. Most of the time it's likely done by the nurse. And then what would happen is if they saw any concerning findings, they would pass it along to the appropriate person. Maybe they would pass it on to the pharmacist, who would then look at medications. They may pass it on to the social worker, who would look at advanced care planning, goals of care, and those types of things. Or they would pass it on to the physician to say, I think we need to change this order. So that's kind of how we tried to support the management of care transitions.
Yes, please.
We'll talk a little bit more about that. So based on these aims and primary drivers and our thoughts on how to get this directed, this is what we came up with for our approach. So we have three items as our primary drivers, basically, of what we're trying to accomplish. Staff empowerment, management of care transition,
really
and
hard.
easy
That's
access
the
to care.
problem. So, but it's.
So that's kind of, and you can read.
You have to assume that there's
that to you. That's how we came up with all of that. That's what we just talked about in the last slide. So now we'll talk a little bit about our numbers currently, and then we'll have a little bit of time for questions.
Their diet specifically, but it's
so currently, as of July 2017, which is the most recent data we have six.
Sort of, drank by farmers in those regions, which is basically it's sort of like an alcohol sugar-based drink, and used mainly for pain as well because it's stressful work. So, other questions? Yes. Right, and I think the only thing is that, when you have a slightly higher BMI, I'm not saying that you get obese, but if you have a slightly higher BMI, you're more likely to adapt to weight loss. So acute weight loss, as a result of sort of, solute loss. That may be difficult if you're already thin and you're losing sort of water weight. So in turn, your risk of even conditions like rhabdomyolysis are probably higher if you're thin stature, if you're underweight. That's sort of the correlation which they look at. But again, being obese is a direct risk factor for CKD as well. I don't think any of I think the point that was being made was not that any of these farmers were sort of overweight. It was just that if you had a slightly higher BMI, you did better than people that were lower BMI or normal BMI. Other questions? Yes. Right, so that's actually a very good point. I didn't bring it up, but there's actually some work now looking into instance of leptospirosis as well, with correlation to some of these areas of farming, especially in the Pacific coast of Central America. There isn't any large-scale, data on it yet, but that's one of the conditions that has been linked in some of these, regions as maybe one of the additives towards CKDu. So yes, leptospirosis is one of the potential causes. Other questions? Oh, sorry. Do the remote sides have any questions? No? Yes, please. That's a very good question. I don't think that a lot of them actually are referred early enough to be worked up for a kidney transplant. They would certainly qualify. I mean, especially, if they're at the latter stages of, kidney disease, they would qualify for kidney transplantation. I think there was one paper that I looked at in which there was one particular town in India that had a really high incidence of referrals for kidney transplants. And when they sort of backtracked and looked at who were these patients, there were actually a lot of them were engaged in sort of, not just agricultural work, but sort of heat, activities in which they were exposed to heat. So yes, I mean, it can certainly lead to an increased, referral. But again, a lot of these patients don't even get to that point. They're basically dead before then. Yes. Mainly, education about how do you work in heat stress conditions. That's really the crux of the thing, and how do you hydrate yourself. And that would be true for anyone actually. Now, again, the general feeling about AKI always was that it's reversible, and it certainly is, as long as it doesn't reach to the point of severe injury. So as long as you're still in sort of that risk category, and you have a brief period of dehydration, that wouldn't mean that you would develop CKD. It's this repeated pattern, maybe on a daily basis or intermittently, that would lead to this increased risk. So yeah, hydration practices, and how do you sort of manage yourself in conditions of heat. Other questions? Okay, thank you. Thank you.